could do that. So if anybody has heard about ketamine, being used in a therapeutic session, we're going to answer those questions here today and help you learn. Who here knows what ketamine is? Show of hands. Oh, wow. I didn't know what it was when I took it in 2006. It led to a very crazy night in Las Vegas, in the Mandalay Bay. I fell into what they call a K-hole. So, ketamine was one of the things that kind of scared me for quite some time until I understood how it's used and how it's used in this therapeutic setting. And, every modality has its drawbacks and its positives. And that's one of the things that we're able to learn here today and find what is right for you. So without any more ado, I'd like to introduce Dr. Joe.
Thank you. Hi there. Perfect. We have okay. How are we doing today? Good. Well, my name is Dr. Joe Pullara. I'm one of the owners of InnerVision Psychiatry. Our tent's right outside the door. I'm a board-certified adult psychiatrist, and our clinic specializes in IV ketamine treatments for mental health, so PTSD, depression, and anxiety. So, here we are. Let's see if we can get this working today. There we go, perfect. So my talk today is the truth about ketamine, but we would really be amiss if we didn't discuss the truth about mental health treatment currently in America. So when you look at the current state of treatment, you think of things like Prozac, Zoloft, Lexapro, the SSRIs, the SNRIs of the world. Now in psychiatry, everything that we do is based off of this study a lot for depression treatment. It's called the STAR-D trial. What they did was they took people who were depressed and gave them an antidepressant, citalopram or Celexa. If you remained depressed, you went down to the next level of treatment, whether switching into psychotherapy, adding a different medication, or adding another one in combination of that one. If you're still depressed, you go to level 3, still depressed, go to level 4. What they saw with the results of this were not terribly impressive. So at the first level of treatment, 37% of people went into remission, meaning they no longer met criteria for a major depressive episode. As they tried more and more medications, they had less and less of a chance of going into remission. Now, the authors of this study said, well, don't look at that. Look at our total. Out of the initial, let's say 100 people, there's much more than that. Out of the initial 100, 67% of people at the end were in remission. So these numbers, while they don't look impressive, they're like, well, 67% of people weren't depressed anymore. But just recently, there was a reanalysis of that data that was out, and go figure, some of the numbers were a little manipulated. And so how'd they do that? When they were going from level to level, they let some people go into the next level and be included that were no longer depressed. 125 people were already in remission, but they were included in the group that they were trying to figure out if they had already had a response. So naturally, it's going to be higher. They also used this different rating scale. When they had the trial approved, it was supposed to be using this HAM-D rating scale. Turns out they made their own rating scale, the authors of the study, and that's the rating scale that they used to get those numbers. So it's been kind of called into question lately. When you look at going to see your psychiatrist or going to see your doctor now, whether it's your primary care doctor that prescribes your meds or your psychiatrist, things have been so condensed now because of insurance constraints. Everything turns into this 15 to 20 minute med check. And if that medication doesn't work, there's no definite algorithm of where do we go next. It turns into, well, we can try this one or we can try that one. Let's see how this one is. There's no definitive algorithm behind it. And it's not diagnosis specific. So like anxiety, we try this one. Depression, we try this one. And naturally, that's pretty frustrating. When you look at the problems with therapy or issues with therapy, oftentimes it's so hard to even get somebody to go to therapy. If you have like a spouse or a loved one or a teen, it's hard to even just to get them to go. then oftentimes there's really no end goal in sight. So I have people that we see in clinic that say, I've been in therapy for 20 years. You've been in pretty bad therapy. With therapy, there should be an end goal, and oftentimes it's hard to get to that. And then it's hard to figure out who's a good therapist and which therapist, just pretends to specialize in everything but knows nothing about one specific thing. You go to Psychology Today or something like that to try and find your therapist, and it's so difficult to figure out who's good, who's not good. Oftentimes it's kind of like dating. You need to find the right person that understands you, you understand them, and it could be a frustrating process. So when we look at this term treatment-resistant depression, it's lately falling out of favor, but we commonly think of it as a failure of 2 full antidepressant trials. Now, when you look at the overall number of people who get treated for depression in America, 1 in 3 people is going to find themselves in that treatment-resistant category, which then leads to some of the things you see like this article in Newsweek. Antidepressants work no better than sugar pills, and for a lot of people it feels that way. There's new studies coming out saying the placebo response rate is incredibly high in things like depression, anxiety, PTSD. Now, what are some of the alternatives? Maybe if anyone who has seen One Flew Over the Cuckoo's Nest recognizes this scene of ECT. Now, ECT, while it may be portrayed very scary in the media and movies, it's actually one of the best treatments we have in psychiatry, but it's pretty labor intensive. You have to go under general anesthesia. It's 3 days a week. They commonly do it at like 6 a.m. in the morning, and you're not allowed to drive for the entire month that you're having it. So for most people, that doesn't work out logistically. TMS, transcranial magnetic stimulation, is another treatment modality that is sometimes pretty helpful for a lot of people and has had some good results, based on what trial you're looking at. But the logistics of that one is you'll have to go for 36 treatments all in a row. So every day for 36 treatments, for a lot of people, that's not realistic. Now, along comes ketamine. Now, ketamine itself, the molecule, was developed in the 50s while they were trying to find this ideal anesthetic. It's developed as an anesthetic, eventually ends up coming out in 1970 as Pullara. We're using it a lot in Vietnam, on the battlefield. Ketamine doesn't have the same sort of cardiopulmonary effects, the heart rate, breathing, as some of the other anesthetics. So it's kind of the ideal wartime anesthetic. Ends up getting added to the Schedule III in 1999, which technically means it's defined as a drug with a moderate to low potential for physical and psychological dependence. Now, when you think to yourself, well, how does that work? We're using it in psychiatry. How does it work in psychiatry? Well, there's really 3 parts to it. Now, this part is the most interesting to me, but I'm not going to bore you with a bunch of receptors that you don't know what they do or what it means. What you can take away from this slide is that your SSRIs and your SNRIs, that's selective serotonin norepinephrine reuptake inhibitors. The goal is to try and increase the level of serotonin or norepinephrine to hopefully make you less depressed. How this works is it hits a receptor called NMDA. So it binds to that receptor. There's a lot of things that happen behind the scenes. Ultimately, this receptor cascade happens that leads to what we know as synaptogenesis or neuroplasticity, which are very big fancy words that basically just mean new neuronal cell growth. So they've been able to prove this with a rat model. They'll take a cross-section of a neuron before ketamine and then look at it again after ketamine. And what you can see with the circles are the dendrites of the neurons, basically the arms of the neuron outgrowing, making new connections, repairing old damaged connections from previous trauma, depression, and anxiety, and allowing you to see your life from a different perspective. Another way to think about the benefits of ketamine is what's called the default mode network. So this is an area of the brain that we've come to find out is basically your brain's autopilot. So now for someone who's not depressed or anxious, no trauma, your autopilot might just be, oh, you know, I was meant to go get the weed brownie from this one guy. I got to go back there. Or, oh, you know, I got to wash the dishes when I got to get home. Or, you know, what am I going to eat for dinner? It's just nonsense, kind of mindless in the background. Now, for somebody who's severely depressed or severely anxious, their default mode network is, I suck. Everybody hates me here. People in the room are probably looking at me because I dressed so stupid today. I might as well just kill myself. No one's even going to go to my funeral. Everybody hates me. And it's that all the time, and it's hard to turn it off. So what ketamine does, which we've been able to show through functional MRI imaging, is that it turns the volume down of that default mode network, allows you to break from that rigid way of thinking and see your life from a different perspective. Now, the clinical evidence for ketamine has been building up since the 70s, dating back to a study in Iran, which described mind-expanding effects, then to Argentina and Germany. Eventually, in the United States, up at Yale, we have a study come out in 2000 where they gave a low dose of ketamine at 0.5 milligrams per kilogram infused over 40 minutes to subjects and monitored for depression resolution. And what we can see is even at one day, the first 24 hours, we had a break from placebo showing a good response. Now this gets replicated and replicated. In 2018, we see a longer study, which ultimately shows us with this dosing schedule, 0.5 milligrams per kilogram, twice a week, over 2 to 3 weeks, leads to a well-tolerated response, no cognitive side effects, memory impairments. They didn't have any bladder issues. They had a 50% response rate and no evidence of drug seeking or abuse in this study in Colombia. Now, this graph here shows how much the rest of psychiatric research is really picking up. So the x-axis here on the bottom is years, and the y-axis is the number of publications. Every year we see more and more publications coming out related to ketamine because it's a new kind of exciting treatment modality. Another big reason is because of suicide. Suicide is incredibly common, unfortunately, in the United States, and during the pandemic it just got worse. We saw the rates of suicide increase by almost 60%. If you think about that in numbers, 12.3 million Americans seriously considered it. Another quarter of them planned a suicide attempt, and half of those folks attempted suicide. Our veteran population at 50% even higher risk to commit suicide. And kind of a sobering reality is that 1 person every 10 minutes commits suicide in the United States. This talk has gone on for about 10 minutes. So it's something it's very important to me and our clinic because it's commonly poorly treated and undertreated. So the evidence for ketamine in suicidality is incredible. This study here is from a meta-analysis out of one of psychiatry's biggest journals, the American Journal of Psychiatry. And what we can see here is, so they use this scale called the MADRS and HAM-D. Those are 2 scales that we use to measure the symptoms of depression. And one of the items of that scale measures suicidality. We see separations from the placebo at day 1 out to day 7 in this trial, which is something you're not going to see in any of the other antidepressants openly available in the United States. Sorry, I'm going to take a sip of water. So that's the clinical trial world. That's a very standardized, tight-knit, kind of controlled environment. How is ketamine treatment in the real world? Well, this study just came out looking at different clinics across the country. So how well did ketamine do in this one? Got 10 different community clinics across the country, a huge study, 836 people. Commonly in psychiatry, the numbers are much lower than that, compared real world data to patients undergoing standard medical treatment. And what they showed was a significant reduction in anxiety and depression after 6 treatment. Now their measurement was a Cohen's D, which probably means nothing to anyone here. It's a measure of effect size. So the measure of effect size in this study shows 1.17 and 1.56 for anxiety and depression. Now, when you compare that to the effect size of something like, let's say, Prozac or Zoloft or any of the SSRIs, their effect size is 0.3. In the research world, 0.3 is a small effect size, 0.5 is a medium effect size, and 0.8 or higher is a large effect size. Then they even showed greater reduction in depression at 8 weeks when they compared it to the standard treatment. Now, another interesting thing they found in this study was that there's a certain subset of the population. Commonly at our clinic and most clinics across the country, we do 6 treatments because that's been the longest running protocol and the largest amount of clinical evidence. They found that a certain subset of the population will go on to respond if we extend that to 10 to 12 treatments. So that was also kind of an interesting finding in this study. Well, oftentimes I get the question, well, how long is it gonna last? Am I just going to feel better for a little bit and then not feel better anymore? Well, this study took all the way out to 26 weeks, a little over, sorry, is that weeks? Yes, all the way out to 26 weeks, which is longer than any of the other studies to date. Now, if you're like, okay, well, that's not really that impressive of evidence, you have to remember back to my first slide about the STAR-D trial. The STAR-D trial, when you're at level 5, 6, level 4, you're at like a 11, 13% chance that you're gonna go into remission. So the likelihood is significantly lower. Then also there's no guidelines, there's no protocol, there's no algorithm when you get to having failed 5, 6, 7 different medications. At that point, you're probably under 10%, under 5% chance of that's the one that's gonna be successful. And then even at that highest level in the STAR-D trial, they're using things like a MAOI, a monoamine oxidase inhibitor, venlafaxine, Effexor, mirtazapine, Remeron. These carry significant side effect profiles, significant burden of side effects. The MAOIs, you need a very specific diet. You can't have wine, aged cheeses, sushi, so it's very limiting. So why would you choose something like IV ketamine? There's other formulations of ketamine out there. Specifically, there's one called Spravato or S-ketamine. So ketamine molecule itself is what they call an enantiomer. It means there's a left side and a right side, S-ketamine and R-ketamine. What Janssen did, it's under the umbrella of Pfizer, was patented the left side of ketamine, the S-ketamine, and formulated it into a nasal spray. So the nasal spray is given twice a week for 4 weeks, or at least that's how it's supposed to be given. Sorry, it's my wife. So some people say, well, I don't like needles. I don't want to do the injections. I'll maybe just do this. And that has been helpful for a certain subset of the population. They do respond well to Spravato, but there are some downsides. It only comes in 2 doses. One is a smaller dose, it's basically a tester dose, and another one is a little bit higher of a dose. But you have to think about what's called bioavailability. How much of the medication that you inject into your nostrils is actually going to be usable by your brain? In the nasal spray, it's only 45 to 50%. In IV, it's 100%. That makes it easier for me to decide what's the right dose that you're going to respond well to. Whereas with this, you only get 2 choices, and if the highest one isn't high enough, then it's not going to work for you. Now, sometimes insurance will cover that, so people are like, well, I want to try this one first because my insurance is going to cover it. Well, what's interesting to note about that is this is directly off of how well does ketamine compare to Spravato? So there's been several different papers these are both recent papers that came out comparing IV ketamine to Spravato. Now, IV ketamine's got a better overall response rate and remission rate, and there's lower amounts of dropouts. This is a pretty big meta-analysis. Another one comes out basically saying some similar things. Some of the results in this study were a little closer in response rate in remission, but the IV ketamine worked much quicker than the Spravato. This is on Janssen's website. Janssen, the makers of Spravato, which is very interesting because in the real world, not in a clinical trial world, what does it look like when you're actually at the clinic? Only 47% of people actually make it through all of the protocol. Their protocol, which if you read like the back of the like the insert, the package insert, it says you're supposed to have 8 treatments over 28 days. In this study, 47% of people only made it through. And then if you look at the average number of days, 80 days. That means they're not even doing it like it was approved in the trial, so the response rate's probably going to be even lower. Well, why not? Insurance is a huge headache, a gigantic headache. Sometimes it takes up to 6 weeks from when your doctor says, okay, I'm prescribed this for you, before you could actually start, because they got to do prior auths, and then they'll approve one treatment, and then you come back for your second treatment, and then all of a sudden it's not approved, and then your doctor has to do another prior auth, and then insurance makes it as difficult as possible for you to have this treatment. That's why a lot of places will start doing it and then ultimately end up stop doing it. Now, some of the other stuff that's going around now is these lozenges, sometimes known as troches. In my opinion, there's minimal evidence to support their use versus something like IV ketamine. There's a lot higher risk of adverse side effects as well. Specifically, if you've heard anything about ketamine, you probably have heard the term ketamine bladder. That's what's called interstitial cystitis. It's an inflammation of the bladder wall. When you take ketamine orally, a large part of it is metabolized by your liver, known as what's called first-pass metabolite. So one of the metabolites, norketamine, inflames the bladder wall, and it puts you at a much higher risk of having cystitis than something like IV ketamine. There's also what's known as a laryngospasm, where your larynx tenses up and it becomes difficult for you to breathe. So having that happen while you're at home, I imagine would be incredibly dangerous and incredibly traumatic for you as the patient. Now, there's places like Joyous, New Life, Mind Bloom, Better You. They'll send huge doses to your house and, make you like wink on camera that you're going to have a sitter with you there the whole time, but it's incredibly unregulated currently, and in my opinion, pretty dangerous. Then on top of that, the bioavailability of something like a sublingual ketamine is only 30%, and that's an average. Meaning, if you're somebody who metabolizes it more or less, you're going to get even less. So it's going to be so hard to figure out what the right dose would be. Now, some people have responded really well to it, and if it has been working for you, I mean, that's great. But if you're trying to decide between the two, I think there's significantly much more evidence for IV ketamine. Now, oral ketamine is also becoming more and more of a thing in pill form. It's got even lower bioavailability at 10 to 12%, so you have to have a much higher dose. It's difficult to find the right dose, and insurance isn't going to pay for this either. So the last thing I kind of want to talk about in terms of oral ketamine, there's a new study that just came out. I saw this in Forbes and the New York Times and the Washington Post, and everyone's talking about this new study about a long-acting formulation of ketamine in pill form that's moving on into the second phase of phase 2 trials. This study was one of the most poorly designed studies I've ever seen, because what they did was they took people who met criteria for depression, they gave them 120 milligrams per day for 5 days ketamine, and then if they responded well, they got to be in the study. If they didn't respond well, they weren't allowed to be in the study. So they naturally selected people who they knew were going to do better on this medication and then tried to say that it was randomized. Eventually, they split the groups up into 30 milligram, 60 milligram, 120 milligram, 180 milligram groups. And of those groups, only one group showed positive results, and that was the 180 milligram group. So there's also the largest ketamine group in the United States, the American Society of Ketamine Providers. They just also recently came out with some cautions and advisory comments about oral ketamine and some of the other things that are being seen online. There's this new liquid injection of subcutaneous ketamine where they have you inject it in your abdomen. Could lead to like a incredibly painful abscess that you'll ultimately need surgery to remove the abscess in certain cases. They're saying the sublingual model, they have you hold it in your mouth until you build up a bunch of saliva, and then you have to spit it out. It could potentially be deadly and much higher risk than something like where you're at the clinic, you have an IV, we're monitoring your vital signs in a safe setting. It's also just less potent, less durable, less predictable. So how do we make our treatments more effective? Now, ketamine, we know, enhances bonding, enhances learning, connectivity, decreases the volume of that default mode network. I'm sure I don't have to tell this crowd about set and setting. The importance of that set is your mindset, your expectations, your fears going into treatment. The setting is what we have kind of tried to create, a very calm, tranquil, peaceful setting where you're safe, you're with a nurse who's monitoring you. I'm in the clinic, my partner, Dr. C, is in the clinic, but it doesn't feel like you're at the doctor's office. It feels like a kind of a spa, tranquil, peaceful kind of vibe while you're there. Now, some of the most frequently asked questions that we do get commonly are about side effects. Now, every medication carries risk of side effects. Ketamine's no different. But the effects are usually very mild and transient, meaning they go away within an hour or two, whereas something like an SSRI that you're taking daily, those side effects, if you do have them, sometimes can be much worse. So the main things that we will see is like some mild nausea, a bit of dizziness, but you're in a recliner. We have eye shades, we have headphones to try and minimize some of that. We have some medications that we can give you to help with nausea. There's some mild increases in blood pressure and heart rate that goes back to normal after the infusion. Now, dissociation commonly gets associated with ketamine, and the field of psychiatry is sort of split when it comes to whether or not this is a side effect or part of treatment. I kind of lean towards it being part of treatment, but we've had plenty of patients in clinic that don't have any dissociation who did incredibly well and are no longer depressed or anxious. So I don't think it's necessary, but it's something that you need to be aware of could happen going into it. Compare that to the side effect profile of something like a Zoloft or Effexor, Lexapro, some of the SSRIs, SNRIs, and you see it's significantly worse. These numbers come from a website called UpToDate, where doctors will look at the most up-to-date information, and these come from the FDA's clinical trials, which are 8 weeks long. So they saw this number of side effects in the first 8 weeks. This doesn't encapsulate the real-world population who takes these medications every day for years. But even then, something like sexual dysfunction, perfect segue from our last discussion, sexual dysfunction, over 50% of people on something like Zoloft, something like Celexa or citalopram, over 70% in a recent trial that was just released last week. Weight gain also be incredibly significant as well. It just turns off your ability to feel full. I've had people tell me. Now, they'll ask, can I take my meds during treatment? For the overall majority, yes. Things like lamotrigine, Lamictal, kind of seen evidence for and against either way. Benzodiazepines like your Xanax, Klonopin, Ativan, temazepams of the world. Our goal would be that you don't take it the day before, the day over, the day after, but there have been some studies to show that taking it and not taking it has no difference on the effect of ketamine. Bladder damage, we kind of touched on that briefly. Much more common in the oral formulations of ketamine because of how it's broken down by the liver. The breakdown products inflame the bladder wall. If it does happen during your IV treatments, there are some supportive treatments that we can add to the infusion to make that less significant. Is this treatment addictive? Commonly get that question, which will eventually lead into our panel in a little bit. So there are some rat models showing potential for abuse, but look at the doses they're giving these rats, and this is daily. 2.5 to 5 milligrams per kilogram. That's enough to sedate an elephant, whereas our clinic does 0.5 milligrams per kilogram. Now, I have seen 0 studies that have come out and said that patients transition from IV ketamine clinics to abusing ketamine off the streets. That just simply doesn't happen to any degree of commonality. But with some of the oral ketamine, the FDA put out a warning in October of last year against the unsupervised ingestion of this compounded ketamine from some of these pharmacies that are popping up. Then you look at something like Matthew Perry's death of last year, which had happened like the day before this Cannadelics last year. Matthew Perry didn't die from ketamine per se. Matthew Perry took a huge dose of oral ketamine at home in an unsupervised setting and then went swimming in a hot tub and drowned. So then the media will portray it as though ketamine killed Matthew Perry, but anyone familiar, you talk to anyone in any clinic that does ketamine, ketamine didn't kill him. Unfortunately, unsupervised use with high doses killed Matthew Perry. Now, if you want more information, you can find it on our website here at InnerVisionPsychiatry.com. We have an extensive FAQs page. Our social media has a lot of informational content about, what conditions are right, what conditions make me not a candidate, how many treatments, do I need maintenance, all things that you may wonder you can find on our website on our FAQ page. And then if you want to read a little bit more, I founded a psychedelic journal in residency called the American Journal of Psychiatric Psychiatry. We publish quarterly on things LSD, psilocybin, ketamine, ayahuasca. If you're interested to learn more about that, we also, if anyone is like a medical student or a student, we do take abstracts year-round. So thank you for your time.
Thank you, Dr. Joe Pullara. Very interesting how things are changing and how these psychedelics are being incorporated into traditional medical practices and being used in this therapeutic setting. So our next panel is very dear to me, and it's going to be on ayahuasca. So how many people here have experienced or sat with ayahuasca? Oh, wow.